In JACC, researchers reviewed published clinical trial data on the effects of renin-angiotensin system inhibition using either ACE inhibitors or ARBs for the prevention of atrial fibrillation. They aim to define when RAS inhibition is most effective. All published randomized trials reporting the effects of treatment of RAS inhibition in the primary or secondary prevention of AF were included. 23 randomized controlled trials with more than 87,000 patients were thus analyzed. In primary prevention, 6 trials in hypertension, 2 trials in myocardial infarction, and 3 trials in heart failure were also included. In secondary prevention, 8 trials after cardioversion and 4 trials assessing the medical prevention of recurrence of AF were also included. Overall, RAS inhibition reduced the odds ratio for AF by 33%, but there was substantial heterogeneity among trials. In primary prevention, RAS inhibition was effective in patients with heart failure and those with hypertension and left ventricular hypertrophy, but not in post-MI patients. In secondary prevention, RAS inhibition was often administered in addition to antiarrhythmic drugs, including amiodarone, thus further reducing the odds for AF recurrence after cardioversion by 45%, and in patients on medical therapy by 63%. What is the take-home message from all this? Well, the analysis supports the concept of RAS inhibition as an emerging treatment for the primary and secondary prevention of AF, but acknowledges the fact that some of the primary prevention trials were post-hoc analyses. Other areas of uncertainty include potential differences among specific RAS inhibitors and possible interactions or synergistic effects with antiarrhythmic drugs. We need more trials on this issue, but it does sound promising. I'm Peter Block with a CardioSource Heart Minute.